Hello all. In this video, we will be talking about few infections. The infections that we're going to talk in detail and learn in detail are, first we will be learning about actinomycosis. Okay. Then we will be talking about leprosy. Then we will be talking about tuberculous lymphadenitis, which is nothing but your cold abscess or cervical lymphadenitis. And then we will be talking about necrotizing fasciitis. And we will be talking about SSSI in a small note, okay? But the other four we'll be learning in detail. Okay, so first one is your actinomycosis. Actinomycosis. So this is of greater importance in dentistry because we are dealing with actinomycosis. So actinomycosis is caused by Actinomyces israeli. Okay, it's caused by Actinomyces israeli. Okay, it's an anaerobic gram-positive branching filamentous organism, which is a ray fungus. Normally, it is present in oral cavity, tonsil crypts, and dental cavities. They become pathogenic only in the presence of trauma. Okay, three types of actinomycosis is very important in general surgery. One is your faciocervical actinomycosis. When you talk about this faciocervical actinomycosis, it is common in patients with poor oral hygiene. Okay, poor oral hygiene, and major causes will be bad caries tooth, etc. So this organism will produce a subacute or a chronic inflammation for many months to years and produce lumpy jaw. Okay, lumpy jaw, first one, that is only your characteristic word that you have to remember, lumpy jaw. And eventually you have to check mandible, jaws and salivary gland are involved, which will cause suppuration also. So what are the clinical features involved in this? So extensive induration, okay, marked induration of your lower jaw, and gums will give the consistency of a bone. And then you have multiple subcutaneous nodules over bluish colored structure of the jaw, and these nodules will rupture, resulting in multiple discharging sinuses. Multiple discharging sinuses. And this discharge contains sulfur granules. Okay, so this discharge contains sulfur granules, which are gram-positive mycelia surrounded by negative clubs. And here the lymph nodes are not involved. Then if you talk about the second form, that is actinomycosis of the thorax and lung. So when you talk about this thorax and the lung, it is common in children, which is caused by inhalation of your ray fungus. Okay, so over a period of years, this produces actinomycosis of a lung with involvement of the pleura. Later, it involves the chest wall, resulting in multiple discharging sinuses. Okay, there will be even empyema and can easily spread to the liver. And actinomycosis of the next one will be iliac fossa and liver. So when we talk about this commonly occurs after surgery when there is a mucosal injury or your discontinuity, that is after your appendicitis operation. So this organism which are normally present in the gut will slowly migrate to your pericecal tissue, then into the soft tissue, then subcutaneous tissue, and they produce chronic low-grade inflammation. No compromise with bowel lumen. Once the portal penis radical gets involved, it spread to the liver occurs. Okay, clinical features if you talk. So clinical features, history of appendicectomy is present in almost all cases. Okay, 3 to 6 months later, what happens is swelling and fever in the right iliac fossa appears. And this when you talk about this fever, it is due to this pyonia. If you examine the right iliac fossa, there is a mass which is indurated, nodular and fix it. Okay, late stages will produce discharging sinuses, sometimes even the self-granules also. Okay, so what if you see the differential diagnosis of this right iliac fossa, Crohn's disease, then cecum carcinoma, then pericolic abscess also, all that. Now we're going to talk about the treatment. So what is the treatment of actinomycosis in general? So it is a low-grade chronic disease which is difficult to eradicate. Okay, low-grade chronic disease which is difficult to eradicate. We can give injection crystalline penicillin. Okay, crystalline penicillin. Crystalline penicillin is 10 lakh unit once a day for 6 to 12 months, and tetracycline can also be given. So sinuses in the jaw have to be excised and osteomyelitis has to be curated out. And if you, in case of right iliac fossa, it may need this hemicolectomy. Okay, so this is all about actinomycosis. So it's caused by ray fungus, gram positive anaerobic branching ray fungus only through the site of trauma. Three forms we've learned. One is your fascio-cervical, then thorax and lung, and we've learned about abdomen. Okay, so we've learned about abdomen. We've learned about actinomycosis and the treatment part. Next, we'll be talking about leprosy. Okay, so in leprosy, what is the other name of leprosy? You all know. What is the other name? Hansen's disease. Okay, so the leprosy is otherwise known as Hansen's disease. So leprosy is caused by Mycobacterium leprae, which is an acid-fast bacilli. Okay, so acid-fast bacilli. So poverty, poor oral hygiene, and population will facilitate the spread of the disease. So this disease is actually contracted in childhood. Okay, childhood and adolescence, but it manifests after a period of 2 to 5 years. In some cases, it will manifest after a year of 10 to 15 years also. We never know. Okay, then nasal secretions. They are the main source of infection, but active ulcers and sweat also contain lepra bacilli. Okay, this leprosy predominantly affects your skin, upper respiratory tract. Okay, skin, upper respiratory tract, and nerves. This characteristic lesions of leprosy will include an anesthetic patch of the skin, thickened nerves, and leonine facies, lion facies, and collapsed nose. So what are the characteristic lesions? One is your anesthetic patch. You will not have that, the touch sensation will be lost. So anesthetic patch of the skin. Then you have thickened nerves, a deformed leonine face and leonine facies, that is lion face, and collapsed nasal bridge, collapsed nose. Okay, so we're going to talk about the types of leprosy. Okay, when you talk about the types of leprosy, one is your tuberculoid leprosy. Okay, what is tuberculoid leprosy? This occurs in patients with good immunity with strong tissue response. Okay, then if we talk about lepromatous leprosy, this occurs in patients with poor immunity with poor tissue response. Then if you talk about borderline leprosy, so this can be borderline lepromatous or borderline tuberculoid depending upon the immune response. Now, if we want to see this in detail, we are going to study about it. So when you talk about this tuberculoid leprosy, the cell-mediated immunity will be strong here, I told. And if you talk about the histology, your Jane cells, epithelioid cells, histiocytes, lymphocytes are present. Bacilli are very, very few. Okay. Then if you talk about the clinical features of it, no, it is localized. Localized, anesthetic, hypopigmented, raised skin patches. So early nerve damage, nerve thickening is a characteristic feature. And involvement of face and nose is not seen. When you talk of the prognosis is very, very good actually for this. Prognosis is good. So when you talk about this lepromatous leprosy, here the cell-mediated immunity will be very low. If you talk about the histology, we all know, no? This bacilli distance into the macrophage is called globi. They are a pack of cells, okay? Globi, plenty of bacilli invading the nerves, adnexa and the sweat glands. So when you talk about the clinical features, it is generalized. Erythematous, multiple nodular rashes will be there. Nerve involvement is not usually seen. Then you have this leonine phase. Then nerve involvement. Collapsed bridge. Collapsed bridge of the nose are characteristic. The prognosis is not that much good here, okay? So when you talk about this treatment, when you talk about the treatment of leprosy, okay, you're going to talk about lepromatous and borderline lepromatous disease, okay? So when you talk about this treatment of leprosy, mainly it is a 3-drug regimen is most suitable. One is your dapsone, 100 mg per day, and then clofazimine 50 mg per day, and rifampicin is 600 mg once monthly, and clofazimine 300 mg once monthly supervised. So this is for a period of minimum 2 years, okay? And skin smear should be negative. When you talk about this tuberculoid leprosy and borderline lepromatous paucibacillary leprosy, only this dapsone, clofazimine, dapsone 100 mg daily, and this clofazimine won't come. This rifampicin 600 mg once a month is given. Now we're going to talk about the deformities in leprosy. If you see, mainly you have a primary deformity and a secondary deformity. Primary deformity, this occurs due to disease. Mainly, the face is described as the leonine facies. Okay, leonine facies with multiple nodules over the face, loss of lateral portion of the eyebrows, that is we call as madarosis. Okay, collapse of the bridge of the nose. Okay, why? Because of the destruction of a nasal cartilage and paralysis of your facial nerve. Then if you talk about the hands, the ulnar nerve will be involved at the elbow, and your median nerve at the wrist will give you claw hands. Okay, then if you talk about the foot, posterior tibial nerve. Okay, posterior tibial nerve will be involved at the angle leading to clawing of the toes. Okay, and foot drop occurs when lateral popliteal nerves below the knee joint is involved. Then you have small ulnar nerve abscess and small muscle atrophy in your hand. That is very, 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 very important. Ulnar nerve abscess is very, 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 very important. Nerve abscess. Okay. Then I'm going to talk about this ulnar nerve abscess. This ulnar nerve abscess may be a part of neurotic leprosy. Okay. Here, this ulnar nerve abscess, it presents as your This ulnar nerve abscess presents as an oval fluctuant swelling on the medial side of the arm. Okay, here your granulation is common, granuloma is common, and progression to abscess occurs in tuberculoid leprosy. Okay, if you take MRI, no, this gadolinium is there, no. So you have T1W sequence in this, where you will have a peripheral limb enhancement with central necrosis. Okay, then this is your ulnar nerve abscess. Then if you talk about this correction of deformity of the face, we've learned about all the deformities. Okay, now how do you correct this primary deformity? Plastic reconstruction, prosthesis, and Tarsorrhaphy also to prevent keratitis. Okay, then if you talk about this secondary deformity majorly will be your nerve sensations will be impaired or lost. As a result of this, on the fingers you will have ulcers, deep penetrating perforative ulcer over the sole of the foot, and even auto amputation of the toes can occur. So when you talk about treatment of the secondary deformity, obviously you apply a POP over your posterior slab. Okay, it takes off the pressure and thus your ulcer will heal. If calcinous is involved due to osteomyelitis, then we can cure it the bone, and then you can then you can do the dressing. So from first what we've seen in leprosy is otherwise known as Hansen's disease. This is caused by Mycobacterium leprae, and it's a disease of childhood or adolescence. Then you have three types: tuberculoid, lepromatous, and borderline. Then we've seen about the deformities. Then we've seen about what are the difference between tuberculoid leprosy and lepromatous leprosy. And then we've seen about primary deformity and secondary deformity. And we've in between, don't forget, we've learned about ulnar abscess also, where your squam cell is affected, and slowly the whole endoneurial zone is occupied by the endothelial cells. The next lesion that we're going to talk about is your cervical tuberculous lymphadenitis. Cervical tuberculous lymphadenitis. This is a definite essay or an important short note you might get. So stay focused. So the lymph node tuberculosis constitutes nearly 20 to 40% of your extrapulmonary tuberculosis. So this is common in children, women, and more in Pacific Islands and Asian country. So this is caused by what? Mycobacterium. It's caused by Mycobacterium tuberculosis. Mycobacterium tuberculosis, atypical mycobacteria, and Mycobacterium bovis. So when you talk about the etiopathogenesis, in 80% of the cases, this mycobacterium will pass through the tonsillar crypt, okay? Tonsillar crypt, and affects the tonsillar node or jugulodigastric group of lymph nodes in the anterior triangle of the neck. In the 20% of the cases, it will affect your posterior triangle due to the involvement of adenoids. Okay, rarely this infection can spread from the apex of the lung. Organism will directly penetrate Simpson's fascia. Okay, Simpson's fascia. I will tell you what is this. Simpson fascia is a subpleural membrane. Okay, suprapleural membrane, and it can cause the enlargement of the supraclavicular lymph node. So other lymph nodes in the neck, such as preauricular, submandibular, can also be affected. In general, the incidence of lymphadenopathy will be like, majorly it will be like neck. First it will be neck, then it will be axilla, then it will be abdomen, and last will be inguinal canal. Okay, so when you talk about the clinical features, tuberculous lymphadenitis presents as a gradually increasing painless swelling of your one or more lymph nodes of few weeks to few months duration. Okay, multiple sites will be involved. Certain symptoms like fever, weight loss, fatigue, and night sweats are more common, especially in those extensive diseases. Now you have stages. Okay, so when you talk about the stages of tuberculous lymphadenitis, first stage is your stage of lymphadenitis. So when you talk about the stage of lymphadenitis, it's common in young adults between 20 to 30 years of age. Okay, what happens majorly is your upper anterior deep cervical nodes will be enlarged, and it's a non-tender, discrete, firm lymph nodes or mobile lymph nodes are palpable. Then the second stage would be stage of periadenitis or stage of matting. Okay, so here this occurs due to result of involvement of the capsule, and this nodes will move together and it is firm and non-tender. Okay, firm and non-tender. And here this stage is called stage of periadenitis or matting, where here matting is the pathognomonic of your tuberculosis. Other rare cause of matting would be your anaplastic variety of lymphoma. Then your third stage is what? Stage of cold abscess. Stage of cold abscess. So this cold abscess occurs due to caseating necrosis of lymph node, resulting in fluctuating swelling of the neck. Okay. So what are the clinical features of abscess? So your clinical features of cold abscess would be no local rise in temperature. Okay. Then no tenderness, no redness, soft fluctuant swelling. Then trans-elimination will be negative. On stellocleroid contraction, it becomes prominent, indicating that it is deeper to the deep fascia. Okay, so then what other thing that you can a differential diagnosis would be brachial cyst. Brachial cyst will also be confused. Okay, and treatment of cold abscess, what you have to do, non-dependent aspiration. Non-dependent aspiration by using a white bore needle. Avoid a persistent sinus. White bore needle is preferred because caseous mat material will get thickened, and here you give anti-tuberculous treatment also. Incision and drainage should not be done, okay, because it causes tuberculous sinus. Then the fourth stage is what? Fourth stage is called stage of collar stud abscess. Stage of collar stud abscess. So what happens here? In the stage of collar stud abscess, it results when a cold abscess which is deep to the fascia ruptures to the deep fascia and forms another swelling in the subcutaneous plane which is fluctuant. So cross fluctuation will be positive. Okay, and it is treated like a cold abscess. Then first one will be stage of sinus. Here sinus is a blind tract leading from the surface down to the tissues. It occurs when your cold abscess ruptures through the skin. So tuberculous sinus is the most common sinus in the neck in India. Okay, so this is what you've learnt about this 5 stages of cervical tuberculous lymphadenitis. Now we're going to learn about some extra features like we're going to talk about the investigations. Investigations: complete blood pressure, then ESR is elevated, chest X-ray is usually negative, sputum should be taken, FNAC. That is what your investigation. Okay. Then if you talk about lymph node biopsy, Langerhans cells will be seen. Okay. But if it is a cold stage abscess, aspiration will reveal cheesy material. Okay. Now, pathological types, if you see, caseating type, hyperplastic type, and atrophic type. Okay. So caseating type is the most common type. Hyperplastic, it shows marked degree of lymphoid hyperplasia, and atrophic type is seen in elderly. So after confirming this diagnosis, anti-tuberculous treatment is given. So we will talk about each now. Okay. What antituberculous treatment you give it for lymphadenitis is INH, that is isoniazid, then rifampicin and pyrazinamide. Okay. Then if you take biopsy, aspiration and excision of lymph node along with the sinus wall. Okay. There are certain stages for this lymphadenitis. Your investigation would be lymph node biopsy and FNAC where you give ATT. Okay. Periodenitis also ATT. Then cold abscess, since it's abscess, cheesy material will come. You have non-dependent, you do non-dependent aspiration here. Here after this cold abscess formation here, you do same non-dependent aspiration followed by ATT. And sinus again, edge biopsy of the sinus, which you do ATT. Okay. So this is all about this tuberculous lymphadenitis. Then we're going to talk about necrotizing fasciitis. So what is the thing that you know about necrotizing fasciitis? Necrotizing fasciitis. It means simply it is known as it involves fascia. That's it. We're going to learn other things now. So it's a spreading, destructive, invasive infection of the skin, including deep fascia with relative sparing of the muscle. So muscle will not be involved here. And commonly if you see, lower extremities will be affected. Lower abdomen, groin. It's called Melanie gangrene. Okay, it's called Melanie gangrene. Mainly your lower extremities are involved. Okay. Then causative organism, it's monomicrobial. Okay, monomicrobial. It's due to group A beta hemolytic streptococci. It's called type 2 necrotizing fasciitis. And polymicrobial, it is due to synergistic combination of anaerobes and coliforms. Okay, type 1 necrotizing fasciitis. Very often there is no injury of history when it occurs in lower limbs. Now if you talk about the risk factors, diabetes mellitus, obviously, obesity, corticosteroids and immune deficiency. Now if you talk about the clinical features, sudden pain in the affected area with gross swelling of your limbs, sudden pain with swelling. Then the part is swollen, red erythematous with skip lesions of the skin, necrosis and ulceration. Then if you talk about the skin changes will be very much. You have a bronze hue, brawny induration and crepitus. And you have high degree of fever, jaundice and renal failure. So if you talk about the specific features of type 2, it's caused by Streptococcus pyogenes, and it occurs in young healthy people, and minor aberrations will be a precipitating factors. So if you talk about the diagnosis, how do you diagnose a liquid? Full thickness biopsy, which is taken at the bedside, will give you full diagnosis. Watery pus actually. Okay, watery pus, which is known as dishwater liquid. It's also characteristic. Treatment, surgical treatment and supportive treatment. If you talk about the supportive treatment, first hospitalization, adequate hydration, broad spectrum antibiotics. Start immediately with your vanco treatment, vancomycin and carbapenem. That is the most thing. And surgery involves wide excision, generous debridement. In type 2 cases, you can give high dose of penicillin with clindamycin. That is the only treatment of choice because it's a potential suppressor of your bacterial toxin synthesis. Okay, so we've learned about all the lesions and now we're going to fill the workbook. When we fill the workbook, we'll learn 2 lines about your surgical site infection. Okay, now take your workbooks, we will fill it. The first infection that we're going to talk about is actinomycosis and leprosy. We're going to compare it and study side by side. Okay, so actinomycosis is caused by Actinomyces israeli. Actinomyces is really an anaerobic gram-positive filamentous organism, whereas this leprosy is caused by M. leprae, and nasal secretions are the main sources of an infection, but active ulcers, sweat also contains lepra bacilli, predominantly affects the skin, upper respiratory tract, and nerves. Okay, characteristics, if you see, it's lumpy jaw, multiple subcutaneous nodules over bluish skin, bluish colored skin of the jaw. Nodules rupture, resulting in multiple discharging sinuses. Okay, then you have sulfur granules. Here in leprosy, you have 4 manifestations. One is your anesthetic patch, thickened nerves, and deformed leonine faces, and collapsed bridge of the nose. Types, there are 4 clinical involvement. We have studied 3. Okay, one is your cervicofacial, then is your thoracic, involving thorax and lung, ileocecal, and 4th one is your abdominal. Okay, microscopy reveals sulfur granules and pulse. If you talk about the leprosy, types will be tubercular leprosy. This occurs in patients with good immunity with strong tissue response. Lepromatous leprosy occurs in patients with poor immunity with poor tissue response. Borderline leprosy, it can be borderline lepromatous or borderline tuberculoid, depending on the immune response. So treatment, if you see, penicillin, drug of choice, 10 lakh units per day for 6 to 12 months. Okay. If you talk about leprosy, it is anti-leprosy drugs are given like dapsone, rifampicin, and clofazimine. Okay. Now we're going to talk about this tuberculoid and lepromatous. We've already studied. It's just a recap. Okay. So cell-mediated immunity will be strong here. Here it will be low or poor. Giant cells, epithelioid cells, lymphocytes are present. Bacilli are few. Okay, then if you talk about the histology in lepromatous leprosy, you will have globi. Globi is compared to a pack of cigarette. There your bacilli will descend into your macrophages, and it will involve the nerves, adnexal cells, sweat glands, etc. If you talk about this leprosy, the main thing will be anesthetic, localized, hypopigmented, raised skin patches, early nerve damage, nerve thickening, and nerve abscess. Mainly your ulnar nerve abscess is characteristic here. But in case of lepromatous leprosy, you if you see them, they'll resemble, their face resembles like a lion, leonine faces, and collapsed bridge will also be seen. Nerve involvement is usually not seen in lepromatous leprosy. Then you have leonine faces. Leonine faces, collapse of the bridge of the nose are characteristic. If you talk about the prognosis for lepromatous leprosy, it is not good, very poor, whereas it is good in case of tuberculoid leprosy. Now, if you compare this nerve abscess, I told you the most common nerve abscess involved would be your ulnar nerve, which is in the medial side of the arm. It is mostly seen in paucibacillary tuberculoid leprosy. Most common Mycobacterium leprae habitat is your squamous cells. It will invade the squamous cells, and mostly granulomas formation occurs, and in few cases abscess also occurs. Mostly it occurs when the immunity is high. Okay, tuberculous lymphadenitis. We've seen the 5 stages. what is the cause of this? In 80% of the cases, this mycobacterium pass through the tonsillar crypt and affects the tonsillar or jugulodigastric group of lymph nodes in the anterior triangle. Posterior triangle, 20% of the cases will be affected due to adenoid involvement. First one will be stage of lymphadenitis, where you have enlarged, firm, mobile, discrete nodes showing non-specific reactive hyperplasia. Okay? Enlarged, firm, mobile, discrete nodules showing non-specific reactive hyperplasia. Then you have periadenitis or matting, where you have this large rubbery lymph nodes fixed to the surrounding tissues owing to the periadenitis. Okay, periadenitis is nothing but your matting. Third one will be your stage of cold abscess, where you have a central softening due to abscess formation. Central softening due to abscess formation. Fourth one will be stage of cholesterol abscess, where you have cholesterol abscess formation. And last one will be sinus, where you have a sinus activity, sinus involvement. Next one will be investigations and treatment. I told most of the, once this cold abscess, cholesterol abscess, you will have to aspirate material for acid fast bacilli. The first two will be lymph node biopsy or FNAC. Sinus will be edge biopsy of the sinus. So other treatment options, if you see, it could be ATT here and it will be ATT here also, and non-dependent aspiration with ATT. Okay, here also non-dependent aspiration with ATT. Sinus ATT alone. Okay, we're going to learn something extra known as Pott's disease. Pott's disease is nothing but the tuberculosis of the spine, known as tuberculosis spondylitis. Here, it's a combination of osteomyelitis and arthritis. Cartilages and bone, both will be involved. So, cartilaginous and osteomyelitis, which involves multiple vertebrae. Typically, the vertebrae is affected, most commonly in your thoracic and lumbar spine, upper lumbar spine. Infection will spread to adjacent vertebrae with involvement of intervening disc, loss of disc space height, and destruction of the cancellous bone, which is liable to compression and vertebral body collapse. The deformed spine is termed as what? Gibbous. Okay, it's termed as gibbous. And treatment will be surgery and anti-TB drugs, and the lymph nodes of the neck are best palpated always. The golden rule is, for any lymph node palpation, you have to go behind the patient and check. The head is also flexed passively towards the side for proper palpation. This is to relax the muscle and fascia of the neck. Next, nosocomial infection. What is nosocomial infection? Nosocomial infection is nothing but your hospital-acquired infections. It is called HAI. Acquired infections from the hospital is called nosocomial infection. Infection can be either from patient's own organism, that is self-infection, or organism from external sources. So, surgical site infections, they are the most common, third frequently reported nosocomial infection. The first would be pneumonia, hospital-associated pneumonia, and catheter-related infections. So, SSI within 24 hours is caused by mainly Clostridium and Streptococci. Okay, SSI after 24 hours, after 5 days, 48 hours is caused by gram-negative and other bacteria. Okay, the Clostridium difficile diarrhea is due to administration of various antibiotics. Now, you're going to see about major diseases, right? We've already seen major bacterial infections. Streptococcus pyogenes, a group A beta hemolytic streptococcus, will cause erysipelas, cellulitis. There are separate videos for it. Cellulitis, necrotizing fasciitis, scarlet fever. So when you talk about the infections caused by group A beta hemolytic streptococci, it's be erysipelas, cellulitis, necrotizing fasciitis, scarlet fever, rheumatic fever, tonsillitis, and glomerulonephritis. Okay. Then if you talk about the viridin streptococci, you have endocarditis. This endocarditis is your subacute bacterial endocarditis, SABE, and anaerobic streptococci always causes liver abscess. Okay, so this is a short of what the bacteria causing infections. Last lesion we're going to learn about necrotizing fasciitis. Necrotizing fasciitis is a dangerous and rapidly spreading infection of the facial planes, leading to necrosis of the subcutaneous and overlying skin. Muscle is usually not involved in necrotizing fasciitis. It's caused by beta hemolytic streptococci, beta hemolytic streptococci, and occasionally Staphylococcus aureus, but it may take the form of polymicrobial infection. Patients are almost always immunocompromised with conditions such as diabetes mellitus. So it's termed as Fournier gangrene, okay, when it affects the perineal areas. And Melanie gangrene when it involves the abdominal wall. The underlying pathology is identical wherever it occurs, and it includes acute inflammatory infiltrate, extensive necrosis, and thrombosis of the microvasculature. The area becomes edematous, painful, and very tender. The skin turns dusky blue, okay, and black, bluish and black, secondary to the progressive underlying thrombosis and necrosis. The area may develop bullae and progress to overt cutaneous gangrene with subcutaneous emphysema. Progress is rapid and renal failure is an early complication. Treat with radical surgical excision repeated every 24 hours. Okay, and give oxygen and antibiotics, mainly penicillins. Okay, so this is about necrotizing fasciitis. So in this video, we've learned about first actinomycosis, leprosy. Then we've learned about tuberculous lymphadenitis, necrotizing fasciitis. In between, we've learned about ulnar nerve abscess and surgical site infection. All of these can be either a short note, and mainly this tuberculous lymphadenitis and leprosy can be a essay type in your college. If you have any doubts, please let us know in WhatsApp group. We'll be happy to help. Hope this video was helpful. Have a good day. Thank you.